It's a great pleasure to start our day today by a lecture of the legendary Professor Laurent Palazzo, speaking about pancreatic cystic neoplasm, one of the state-of-art lectures.
Nice to meet you. First of all, I would like to thank Dr. Abed for this invitation. It's the 5th time that I come in this meeting. And years after years, the meeting is amazing, more amazing every year. And I'm very proud to be here. So I start the meeting by these lectures on the routine issue, which are cystic neoplasm. This is my disclosures. So as you know, cystic lesion, it's really an epidemic, and we have now the last figures obtained in this meta-analysis published in 2024, which means that the numbers of cystic pancreatic lesion it's the double that what we were thinking 5 years ago. If you look at it, at between 50 and 60 years, you have around 10% of the overall population, and after 80 years old, you have around 50% of the population which has cystic lesion. The prevalence is the same whatever you use MRI, low Tesla or high Tesla, and of course it depends on the radiologist. When these charts are the standard charts, they found 5% of cystic neoplasm, but when it's independent radiologist, it's 25%. 80% of all these lesions are neoplasm. And the neoplasm, the main neoplasm is IPMN, and the second one, and this the reason why we have so much issues and so much concern in this lesion is serous cystadenoma. And serous cystadenoma, so is frequent, and it's totally benign, and it's the differential diagnosis of this serous cystadenoma make that we have issues in outcomes of these lesions. So you see, you know everything about this risk of malignant transformation, but we will see that it's more difficult than this. So when imaging is typical, there is no need for sampling. Mucinous cystadenoma, for example, when it's typical, you know it's mainly women, it's mainly body and tail. You know that this mucinous cystadenoma, in fact, is an embryological abnormality in women, which is like ectopic pancreas into the antrum. It's ovary inside at the level of the posterior and inferior part of the body of the pancreas in the majority of the cases. Okay, and of course, you have a risk of malignancy. When you have this kind of imaging, you do not need any sampling. You have to give the patient to surgery, or if you do not believe that this lesion will move to the cystadenocarcinoma. And some of the teams in the world, they think that we can follow these ladies when it's 3 centimeters. For me, it's totally crazy because the ladies disappeared 10 years after the beginning of the follow-up and came back 20 years later with a cystadenocarcinoma. So, of course, the majority of the teams operate this kind of lesion. So, it's not easy for serous cystadenoma. Of course, everybody thinks that the typical aspect of serous cystadenoma, it's easy. But because now we stopped using ultrasound in the large department, we use CT, we use MRI, sometimes AUS, but no ultrasound. So this diagnosis started to be difficult during the last 10 years, but it was easy 30 years ago. Even the microcystic type was so easy 30 years ago because we are using ultrasound, and now it's difficult. But what you have to know is that the microcystic type, which is a typical type, is only 45% of the cases. which means that the macrocystic type or the mixed type, which look like mucinous lesion, IPMN or mucinous cystadenoma, is 50% of this serous cystadenoma. And serous cystadenoma is 20% of cystic neoplasm. So the results of this is that 61% of the patients with serous cystadenoma are operated on, which is not good at all. The second, of course, main cystic neoplasm is IPMN. You know all these kind of things, mainly side branch. Of course, when it's a main duct IPMN, which is obvious on CT, MR, AUS, the difference is that with AUS, you see better the mural nodules. And because of the mural nodules, sometimes they have the same density and intensity than the normal parenchyma. In fact, you can have a fantastic MRI with a dilated duct, and in one part of this main duct on the MR, you have the diameter is less big, and you think it's like this, but finally, when you do AUS, you find a mural nodule, and a big mural nodule inside the duct, which is not depicted by MRI or CT. You have to know these kind of things. This is side branch IPMN, and we think that with MRI, we have the communication with the duct, as it explained in all the meetings, in 90% or 100%. It's totally false, totally false. Patient by patient, yes, but cyst by cyst is totally false. And when we are taking care of patient, we have to know that. So MRI is not able to demonstrate a connection between the PD and the side branch in more than 50% of the case. And pseudo-connection are seen in 10%. You have this very beautiful surgical series. You have side branch IPMN operated on, and they look at all the cysts, and you have mucinous cystic neoplasm operated on. And if you look at this, the sensitivity in side branch IPMN, cyst by cyst, to discover the communication was 100%, was 30%. And the specificity was only 90%. So, okay, so it means that it's slightly more difficult than everybody is thinking. So if we summarize the morphology of cystic neoplasm, the main differential diagnosis is macrocystic and mixed macro-microcystic variant of serous cystadenoma. And what you have to know is that macrocystic variant or mixed macro-microcystic variant of serous cystadenoma is associated with IPMN in the same patient in 20% of the cases, which means that you have a splendid IPMN and a big cyst. And the big cyst is operated on because you have an IPMN, and the surgery say serous cystadenoma. So you have cut the pancreas for nothing. So when it's difficult, we need sampling, but we need specific tools. The goal of this sampling is to affirm, to demonstrate formally that it's this or this lesion, not to have suspicion. But if the sensitivity of the test is low, finally, we have no use in standard practice. So we have the viscosity, the CEA, the glucose, the cytology, and we have Cellvisio, molecular markers, and microbiopsy. So viscosity is very, very, very good. The specificity is 100% finally, but the sensitivity is not 100%. But when you do not need any expensive tools. You have the diagnosis of mucinous lesion. The CEA is not so good, okay? When it's very low, it's suggesting serous cystadenoma. When it's More than 200 is suggesting mucinous, but finally, it's really when it's more than 800 that the specificity is near 100% for mucinous, 800. Glucose is better, but the combination of both do not improve the results. So I use mainly glucose. Cytology is not good at all. These are the meta-analyses. Sensitivity 54, 63, you can say, oh, it's good. Specificity 88, 93, it's good. But finally, if you look at these studies which are inside the meta-analysis, they combine lesion with nodules and lesion without nodules. But the lesion with nodules, we do not need any sampling. We have a nodule, and we have to operate it on if the patient is good fit for surgery. So to do a cytology here has no sense. But we need cytology when you have a cyst with a thin wall and you don't know what it is. And in that setting, it's 10% sensitivity of cytology. So cytology has no interest when you need really cytology. Molecular biology, of course, is the future. However, it's $4,000, okay? And it's very expensive. And we have so many patients with cysts that it's a big problem. So if I summarize, when you have GNAS mutation, you have IPMN, okay? You can have now very specific mutation for high-grade dysplasia or cancer. But we do not know if, at all, if this mutation are seen in patients with thin wall or mural nodule. If these mutations are seen in patients with mural nodule, no interest in practice because we have to operate the patient. If these mutations are seen in patients with a normal cyst of 3-4 centimeters with thin wall, very interesting, but we do not know at that moment this. So we are waiting. Intracystic biopsy. Intracystic biopsy, it's easy to perform. 19 gauge, very good biopsy forceps. You see that the diagnosis cost effectiveness is only 66%, so it's not 100. The histological concordance when you have an histology is 100%, so it works. The limitation is expensive, as everything, and you have more complication. And these complications are due to, if you biopsy everything, you will have complication. If you avoid to biopsy all the cysts, everything, you will have less complication and more interesting results. In fact, it's not recommended when the wall is very thin because of the risk of hemorrhage, because when it's thin, it's often cirrhosis adenoma, okay, so you have a big hemorrhage. And it's a risk of fistula if it's an IPMN with gastric, for example, not intestinal, but gastric type, because the fluid, you have no viscosity, and if you make a hole by your biopsy into the wall, because you have a communication with the main pancreatic duct, you will have a fistula. So avoid to do that, really. It's recommended when the wall is visible. When you have a real wall, you can biopsy. And you will have a cystic net, a mucinous cystadenoma, or a side branch IPMN with a thick wall, which is very interesting. It's recommended also in side branch IPMN with mural nodule when the patient is not perfectly fit for surgery. And you want to know if it's low-grade dysplasia and you can continue to follow the patient, or if it's high-grade dysplasia and even the patient is not good fit for surgery, if he's operable, you will operate him. So it's interesting in that case. Finally, it's Cellvisio, okay, you know, it's the best test for this diagnosis. It's the best, but only few teams are using it. For example, this is a large cyst in a young guy of 40 years old, and in the head, you don't know what it is, you do the Cellvisio, it's a cirrhosis adenoma, macrocystic. And you avoid to do a Whipple to a patient with a serous cystadenoma. You see this typical aspect with the red cells moving in this vascular pattern, which is totally specific as histology from here, the same cyst in an old patient, 17.7, and when you do, oh, sorry, how it works, yeah. I cannot play media. 1 hour ago, it was working. I'm sorry. Okay. Look at this. This is the typical aspect of a serous cystadenoma on CT scan. You see, you have a lobulated lesion with septa enhanced with a central scar, and here you have the MRI. You can say it's a serous cystadenoma. If you ask that at the Radiological Congress in Chicago with 10,000 radiologists in front of you, they say, it's a serous cystadenoma. However, pancreas, it's more difficult than what we think. And when you do AUS, you see that it's not the typical of serous. You do a cell visio, and you find an IPMN. And you find an IPMN with a thick black wall, which means that it's highly suggestive of side branch IPMN, and in fact, of side branch IPMN with high-grade dysplasia, and the patient had a Whipple, which confirmed. And this lesion was typical of serous cystadenoma on imaging. So what is important in IPMN is the risk of invasive carcinoma. This is a debate. I am a Japanese fan. These are what are thinking the Japanese expert. The European experts don't think that, okay? They are changing their mind, but they are wrong. And they will discover that in 10 years. Okay, I see IPMN since 39 years. I am the oldest guy in the world seeing for IPMN. The first one was in November 1986. And IPMN has been discovered and described in June 1986, okay, by Professor Itai. So I have 40 years of follow-up of IPMN. And all the things which are said since 2 or 3 years by the European are totally false. These are what is said by the Japanese. In fact, look at this fantastic study of 1,500 patients followed for a big part, more around 15 years in Japan. And if you look at this, when it's main pancreatic duct involvement, you see 40% cancer at 5 years, 80% at 10 years, 100% at 15 years. Everybody knows that. If you look at side branch IPMN, 33% at 5 years, it's accepted, everybody accepts that. 6.6 at 10 years, it's okay, but 15% at 50 years. And what is important, in half of this cancer are concomitant adenocarcinoma. They are not derived from IPMN. They are derived from PANIN. This is the difference between European and Japanese. The Japanese, they know that IPMN is only one of the precursor of cancer, and the other precursor of cancer is PANIN. PANIN is 80% of adenocarcinoma. IPMN is 20% of adenocarcinoma of the pancreas. That's the figures. In the patient with a family of pancreatic cancer, it's always PANIN which is giving the cancer, even you have IPMN. So in everybody, the risk to have PANIN exists. It's the reason why we have pancreatic cancer. When you have an IPMN, the risk is higher to have PANIN in the pancreas. You'll see the risk of ductal cancer in patients with side branch IPMN is 5 times more than the standard population, which means that when you look at the family of cancer, you accept 10% risk more than the standard population, 10 times. Here with IPMN, it's 5 times. Okay, so, and if you look at this side branch, less than 15 millimeter, in Europe, they say after 65 years old, you stop follow this patient if you have no increase of the cyst. These are the new guidelines. It's totally crazy since the risk increase with age. You have no pancreatic cancer, concomitant pancreatic cancer in patients with 55 years old or with at 60 years old. It's not true. The patient are 75 years old when they have their cancer. They are 72, they are 80 years old. You understand? And if you look at this, at 15 years, you have 8% risk, 7.5 risk of cancer in this kind of side branch, less than 15. And 2/3 of them are concomitant adenocarcinoma. These are the Japanese answer. So, okay. Look at this. This is a patient, lady, 77 years old, follow-up, side branch, less than 20 millimeters since 17 years. AUS, I performed since 10 years every year. Last 3 years ago, small 9 millimeter nodule at the body tail junction, CT and MRI done the same day, normal. AUS guided biopsy show cancer, left pancreatectomy, cancer PT1A N0 M0R0, no recurrence at 5 years. It was, this is our role. And of course, we have to do the biopsy. So why I finish by this, AUS should be preferred to MRI for the follow-up of side branch in patients more than 65, so the contrary of the European guidelines. CHAUS is a reference examination for the diagnosis of mural nodule. You know that the mural nodule is the more worrisome features, the more important worrisome feature. And MRI has a sensitivity of 44% only when it's less than 1 centimeter mural nodule. These are the results of the studies on MRI. And AUS is able to find them in 96%. Secondly, 10% of pancreatic adenocarcinoma are undetectable using most modern cross-sectional. But this 10% in expense center, this 10% involve 90% of PT1. 90% of PT1 are not seen on MRI or CT. And 30% of less 3 centimeter. 90% of these undetectable cancers are resectable in comparison with only 25% when CT and MRI find the lesion. These are the results. Okay, the diagnosis sensitivity of AUS-FNB is close to 100% in this kind of PT1 lesion. And finally, sometimes you see something on MRI, it's a stenosis, but you don't see the lesion. You see the stenosis and the dilatation upstream. And you do an AUS to find the lesion and to do the biopsy. So why to continue to perform this kind of MRI when finally you never find what is useful in the lesion, only the increase of the size of the cyst. So in conclusion, specific characterization, which means certain diagnosis, is mandatory each time that you discuss surgery. Avoid to operate serous cystadenoma. And each time that the diagnosis of serous cystadenoma is suspected, leading to shutdown follow-up. So when you say, oh, it's a typical serous, I will shut down, do an AUS and a sampling. And when you would say, oh, it's a typical side branch IPM 5 centimeter, I have to operate it on, do also sampling. To establish the diagnosis of mucinous lesion, we have the clear communication, it's IPMN, the clear communication on MRI, or string test, or positive cytology or histology, or CEA more than 800, or positive NCLE, or specific KRAS GNAS mutation. You have the certitude it's a mucinous lesion. And to establish the diagnosis of serous, positive cytology or histology, or NCLE. These are the only certitude. When FNB is needed, is the key element during the follow-up of IPMN, because the risk of adenocarcinoma is 15% after 15 years. In patients more than 65 years old, the risk of concomitant adenocarcinoma not derived from IPMN is 7% after 50 years. Only AUS is able to identify and sample PT1 concomitant adenocarcinoma. This it's true, and I thank you.